I'm Sky, and this is my knee trigger. Hello,
Hi,
I'm Sky. I'm from the radiology department. Can I get your full first name and last name?
Philip Lopez,
And your date of birth?
5/24/87.
Okay. And is there a chance that you're pregnant?
Nope.
Alrighty. And what brings you in today?
I tripped and I fell and landed on my knee.
Which knee is that?
The right one.
Okay. And how long ago was that?
2 days ago?
2 days ago? Okay. And do you have any buttons or any metal around your knee?
Nope, I'm good.
Alrighty. So I'm going to have you go ahead and lie down on the table with your back down. I'll go ahead and put the shield on you. So I've got it detented transversely, and now I'm just detenting it longitudinally. Make sure that that's good. Okay. So for the first projection, it's the AP projection of the knee, and the central ray is going to enter 1/2 inch below the patellar apex. This is his right knee. So for this projection, as well as the other 3 projections of the knee, I would be using, according to Merrill's, a technique of 85 kVp and 2.5 mass. For the AP projection, I won't be using a tube angle on Phil just because the distance between his as-is and the table is greater than 19 centimeters and less than 25. So this one looks good. There's no breathing technique. There we go. Just collimating to the knee. So, alright, I'm going to go take the x-ray. Phil, just go ahead and stay still. Okay, x-ray. Beep. And the next one's going to be an AP oblique with medial rotation for the knee. So Phil, go ahead and just rotate your knee inwards just a little bit more. Okay, right about there. And for the central ray on this one, it also enters 1/2 inch below or inferior to the patellar apex. I'm just going to move the table a little bit to be in line with his leg. Okay, and his leg is rotated 45 degrees. And we'll go take the x-ray. So Phil, go ahead and just stay still. X-ray. So for the next one, it's going to be the lateral knee, and the central ray is going to be entering mediolaterally. So Phil, what I'm going to have you do is I'm going to have you turn a little bit towards me, and you're going to let this knee drop out towards me, and you'll just flex it about 20 to 30 degrees. So that looks good like that. And so for the lateral projection, you want to put a tube angle on every single person for about 5 to 7 degrees cephalad. So I'm at 6 right now. And this one, the central ray is going to be entering 1 inch distal and medial to the epicondyle of the femur. So the epicondyle of the femur is this part right here that you can palpate pretty sure that it's in true lateral position. Alrighty.
You guys having fun?
Phil, just go ahead and stay still. X-ray. Alright, perfect. So like I said, for those projections, according to Merrill, for manual technique not using AEC, for a normal adult, we would be using 85 kVp at 2.5 for DR and mass. So let's set up for the next ones. I'm gonna go ahead and just, you can go ahead and roll back onto your back, Phil. Alright. Just gonna put the shield back on you. So the next one I'm gonna be doing is the PA axial for the intercondylar fossa. So we won't be using a grid this time. We'll be using a free cassette. There is no tube angle to this, well, there is, but it depends. Maybe I'll see what's going on with that first.
Stop that.
Okay, so we're gonna do the PA axial projection of the intercondylar fossa. So I'm gonna go ahead and shield. And for this one, Phil, you can go ahead and just lean back and relax. The technique for this one is going to be about 73 at 6, 73 kVp at 6 MAS, according to Merrill's. So what I'm gonna have you do, Phil, is just go ahead and bend your knee up. I'm gonna put this under here, and then we're also gonna put the IR under. And so the little green strip goes to your right. Okay. And then go ahead and just move your foot forward for me just a little tiny bit. Right about there. So the knee is flexed at 60 degrees. And the CR is going to be angled to the lower limb. Like that. Okay, and this is his right knee. So perpendicular to the lower leg, like I said, and it also enters the femoral tibial joint space. 40 inches away. I'll double check that. So 35, so I'll go back a little tiny bit more. Just like that. Okay. So Phil, go ahead and just stay still. I'm gonna go take that x-ray. X-ray, beep. Okay, so the next picture is going to be the tangential projection of the patella, and we're gonna do the Setagast method of him holding the IR above his knee. So let me go ahead and put a sponge behind you here. Just gonna have you sit up. Alright, you can lean back a little bit. So I'm gonna have you go ahead and bring your knee as close as you can to your body. Just like that, that's good. And I'm gonna have you go ahead and just hold on to the IR here. For this particular one, I'm gonna have to pull you down a little bit closer to the table. Let's see if we can do that. 2 and 3. Okay. So for this one, the central ray is also going to be perpendicular to the lower leg, and we're going to be shooting through the patellofemoral joint space. And for this particular projection, I would probably use 70 kVp at 4, since we don't have as much tissue to go through as the PA axial of the intercondylar fossa. So, I'm gonna scan. It's definitely not. Thing on my thing. Alright. Sorry, Phil. Okay. And so that's pretty much what it looks like right here. Alright, and so I'll put my marker on the cassette. And that looks good. And so the CR, the angle's not, like I said, with the long axis of the leg. Yeah, that looks good right there. Thank you very much, Phil.
Thank you.
I'll go ahead and take this and run it and make sure everything looks good. You're free to go.
All right.
Okay, so we're going to talk about the knee x-rays now, and what I have here is an AP projection of the knee. The central ray enters about 1/2 of an inch distal to the patellar apex, so you can kind of see right here the apex, so central ray is right about there. For these projections, there's a tube angle, but it depends on the distance of the patient's as-is to the table. So if it is 18 centimeters or lower, then it'll be a 3 to 5 degree caudad angle. If it is 25 centimeters and higher, then it'll be a 3 to 5 degree angle cephalad. For this projection, you can see the femoral condyles are symmetric. There's a slight superimposition of the the fibular head here. The patella is completely superimposed back here, and there's an equal width between the intercondylar eminence on either side. So that is the AP, and so now we're gonna go to the next one. So this is a lateral knee, and the central ray enters mediolaterally, and 1 inch distal from the epicondyle. So basically it's on the condyles of the knee. Okay, so this is the lateral knee, and the central ray enters mediolaterally for this projection, and also for the epicondyles it enters 1 inch distal from that, so basically on the condyles. There is a tube angle on this every single time on every single person. It's 5 to 7 degrees cephalad, and that basically just gets the medial condyle kind of out of the way, and you can see more of the joint space in between. The patella is in profile view, in lateral view. The knee is flexed about 20 to 30 degrees in true lateral, and the way that you know that it's true lateral is when the condyles are superimposed on each other. And then you can also see here the tibial tuberosity kind of sticking out. It's a little rough right there. So we'll go on to the next image. So here we have the AP oblique with medial rotation projection of the knee. For this one, you rotate the entire limb 45 degrees medially, and the central ray enters about 1/2 an inch distal to the patellar apex, similar to the regular AP projection. So for this one, the main thing for the oblique projection medially is that the the tibia and the fibula are separated at their proximal articulation. The patella for the medial rotation is projected kind of off to the medial condyle, and vice versa for the lateral. The lateral rotation one. That's about it. So we'll go on to the next image. And here we have the tangential projection of the patella. We're interested in the patella for this one here. So the central ray enters perpendicularly to the joint space between the patella and femoral condyles. And you can see the intercondylar sulcus here, that should be open. The patella needs to be in profile, so you can see it kind of projected above everything there. This is the Setagast method that I did for the video, and they call it sunrise because it looks like a little sun rising over the mountains. And yeah, that is it for that one. So let's go on to the next image. All right, here we have the apiaxial projection of the knee, or also known as tunnel view. And this is the method that I did in the video is the Baclair method. So for this one, it's pretty similar to the AP projection, except that the main thing for this is that we're looking at the intercondylar fossa, which is right in here. And so this projection just opens this this hole very well so that we can see through there. The central ray is perpendicular to the long axis of the lower leg. So you just kind of have to angle it with however the lower leg is angled and when it's flexed. It also enters 1/2 of an inch distal to the patellar apex, similar to the AP projection and the AP oblique projection. So mainly we just want the intercondylar fossa to be open. That's the most important part here. And you can see the postero-inferior section or surface of the femoral condyles here. So it's looking a little bit from underneath the condyles. You can also see the intercondylar eminence here, this little mountain. And the patella is out of the way. It's, it's projected way up here, and it's not superimposing this section, which is important. And that is it for that.